block drawing test also.
So anything for Hindi speaking people?
So all the tests have got their own Hindi versions also.
Anything simpler than that? There are a number of them MMSC that we have seen. Then there is something called as Hindi mental state examination. Then there is MOOCA. Then there is a ICMR neurocognitive toolbox, which is validated for the Indian population. So out of these, what is the problem with MMSC? Can you use it for research purposes?
Sir, permission has to be taken. Sir.
So it is a paid. You can use it for clinical purposes, but it cannot be used for research purposes without permission. MOOCA, I think it can be used for both clinical and research purposes.
Her lobar function test showed impaired forward and backward digit span, impaired motor luria test, impaired proverb interpretation test, and impaired luria graphia test. She was unable to name animals, and she could not make up the sentences and could not make the picture.
Dr. Shinu. Dr. Shinu. So analyze this lobar function, which all lobes are in.
For impaired forward and backward digit span, like frontal. Impaired motor luria test. It's like motor.
Please be a bit loud.
So, motor luria test for temporal. So, impaired proverb interpretation test and luria graph.
Give the mic to you and the guidance sitting next to you. Major Ram.
Sir, are they impaired motor luria test for motor cortex? Then unable to.
We are not talking about anatomical.
Sir.
We are not talking about motor. We are talking about which part of the motor cortex is in.
Sir, the temporal.
Abhishek.
So the impaired forward digit span, the motor and the graphic luria test, and the proverb interpretation test, so they are involving the frontal lobe, sir. Unable to name animals is also again will come in frontal lobe examination. While cannot make up the sentences, sir. This can have two features, sir. Either they can be secondary to aphasia patient has, which can have a temporal lobe involvement as well. While could not make the picture, sir, it can be because of either ideational apraxia, that patient is not able to draw or follow commands, or it can be because of the visual occipital lobe involvement when the patient has visual deficits and they are not able to make the pictures.
So the first four they localize generally to the dorsolateral prefrontal cortex, and the second, sorry.
Further, on examination, she had an abnormal movement of the right side of the face and the right hand and leg. There was no cranial nerve deficits. The motor examination was normal. The sensory cerebellum has no deficit, and other systemic examination was normal.
Robin, summarize.
Sir, a 13-year-old girl, sir, with a past history of missing vaccination at 9 and 18 months of age, sir, presented with complaints of initially focal onset seizures on the right side, then later on converting to generalized seizures, sir, with history of cognitive impairment, altered behavior, sir. On examination, this patient has a frontal and temporal lobe dysfunction, and on MMSC also she had cognitive impairments.
Psychiatric symptoms, they preceded the seizures.
Yes,
important. We'll see why it is important later. Okay. Next one.
So she had approx 2 months of abnormal behavior and 2 to 3 days of focal seizure to bilateral tonic-clonic seizure event. And with these complaints, she was managed at the private hospital with at psychiatric clinic. However, her condition deteriorated, and then on 30th of August, she was admitted in Command Hospital for further management.
Any pediatric question? So they've been highlighting that she's mixed their vaccinations, chickenpox, at approximately 5 or 6 months prior to the onset of illness. So what is the importance of vaccination?
Sir, in certain due to certain vaccinations, they can also lead to in future they can lead to like autoimmune symptoms, sir. Like
these missed vaccinations, huh?
the infection chickenpox I was talking, sir. Missing of vaccination again poses a risk for getting those infections, sir. Like generally in 9 months and 18 months, we give the MR vaccine, sir. Measles, in the 9 months, we give measles and rubella vaccine, sir. Again, the infection like measles is also associated with the risk of, like if she would have received the vaccine, then we could have thought of conditions like SSPE, sir. But she has not received. Generally, it is associated with that. And it's one of the rare side effects. And regarding varicella also, sir, the infection varicella itself can precipitate the autoimmune encephalitis in some cases.
No, no. And anything else?
And
What
the
vaccination is it?
live vaccinations are associated with the induction, autoimmune encephalitis like symptoms.
So vaccinations, it could be a due to SSP, or it can be a precursor or harbinger of autoimmune encephalitis. Then there's a term called as post-infectious encephalitis. It is seen with almost all the arboviral infections. We are seeing dengue, post-infectious encephalitis. We are seeing chikungunya, post-infectious encephalitis. Then there could be post-infectious demyelination also. So that can also be triggered by infections. So what is your differential diagnosis? Another one?
Sir, with this setting, sir, it can be infectious cause, sir, post-infectious encephalitis, sir, or it can be viral or bacterial, sir, or it can be autoimmune encephalitis, sir.
Okay. Anything else? Pediatrics? Somebody else has to stand up. Please don't complain. Yeah.
Sir,
So
could
can you
be
think of some conditions which are, this age group of 12 to 13 years, it is an overlap between, either she could have landed up with you also, or they could land up with us also. So what would you think of all these patients? With a history of around 3 or 4 months.
sir, could be autoimmune like SLE.
Pediatric SLE.
Sir.
More common than that. The syndromes which are, more specific to pediatric population.
TANs.
Anybody else? Abhishek? Any other?
Since she has history of chickenpox, so post-infectious etiology we need to consider, sir. It can be a bacterial, viral, or a protein. Consider. So then vascular causes, vasculitis can also have a similar presentation. In metabolic causes, sir, even Wilson's and porphyrias can have a manifestation with preceding with neuropsychiatric complaints. And lastly, we need to consider autoimmune phenomena at this age with presentation.
So it's a vast differential diagnosis in these patients. First of all, it will be vascular value studies here for practice, but I'm not very sure how common it is in the pediatric population. Cell infections, bacterial viral infection. Next, then toxins, neurotoxic substances, alcohol, marijuana, cannabinoids, opioids, vitamin. And bodily storage that we need in these patients. Metabolic, genetic, and mitochondrial disorder, and post-infectious. So this is an important cause in especially in pediatric population. Or it could be just post an effect of or the residual damage to the and post-focal neuropsychiatric disorder, then this is to always remember that a girl presenting or a child presenting at the age of 19 to 15 years, there is a history of vaccination, doubtful vaccination, and there could be depression. People doing this. In the elderly population, could be plastic. Plasma, they are more commonly and when TBS can present like this. Then a big chunk is psychiatric disorders, bipolar disorders, conversion disorders. Here she is already been referred by somebody to a psychiatrist, referred as PAS. And in this case, we could always consider child abuse and behavior. In fact, it's very important to take a good history. Then immunomediated virus. Then they do medical things, Panda, pens, those are classic of this. But if this patient goes to he will qualify to file. So what is a photo?
Sir, functional, sir, she has come with frontal subnormal behavior, sir, and with seizure, sir, and physiological lesion likely involving cortex and cortex, sir, and cortex, sir, anatomical is frontal and temporal lobe, sir. Process can be, as discussed, sir, it can be autoimmune, it can be infectious, it can be metabolic, sir, or
So this is our localization. She got a secondary here. This localization cerebral cortex involving prefrontal cortex, some amount of temporal and motor cortex also. It will actually be infectious or immunology balance. So any of the junior training. Yeah, please tell me. Prakar. So what are the features in examination which suggest which point to a cortical involvement in the axis? Please repeat.
So a motor involvement, the ringing hand movements or hallucinations,
Please speak to the mic.
plus motor involvement in the ringing of the hand movements can be cortical function, hallucination.
Sabir, help him.
Sir, seizures on presentation represent the cortical involvement, sir, and more or frontal lobe and temporal lobe involvement can be.
Sir, abnormal seizures, abnormal behavior, cognitive declines, and motor abnormal movements suggestive of such as cortex.
So the moment the patient gets seizures, there is a behavioral phenomenon. On examination, you find impaired cognitive function or apraxia, agnosia. These are all pointers for localization due to the cortex. Next. Psychiatric. What do you mean by pseudopsychiatric? Major subtlety.
So pseudopsychiatric emergencies could mainly imply dissociative disorders like one, basically the ones that can present like an overlap, which have a query of psychiatric disorders with likely, which could point or look alike like neurological disorders. Like in our case, dissociative, like a pseudo seizure, could mimic like a seizure and pseudo seizure differentiation. One is that. Second is if there is an underlying psychotic illness which causes a sudden behavioral abnormality, which can also mimic like an underlying neurological illness, which could be an emergency in itself. Additionally, so.
Dr. Natish.
So,
what do you mean by pseudopsychiatric?
Sir, some of the medical conditions would represent as the acute psychotic-like conditions.
So these are the primarily psychiatric symptomatology is presentation is like a psychiatric disorder, but at the end of the day, they would turn out to be having some neurological or even systemic cause. So these are the risk factors when you see a patient, so age higher than 30 years. When you are seeing these patients in emergency, just the split-second decision that you have to make whether to listen, whether to keep the patient with yourself or ask for a medical clearance, the terminology that we use very much. So these are a few pointers, though not exclusive. The age is higher than 30 years, or there is sudden onset of psychiatric symptoms. There is associated history of confusion, visual hallucinations, or disorientation to time, person, and place. And the symptoms, if they do not correspond to